Hi, everybody. Welcome back to Fertility Fact or Fiction Live. We have a great live show for you today. We are going to be reviewing a hot button topic in the world of infertility, which is the endometrial receptivity array. And we've got a bunch of studies to contribute to our answer for tonight. And of course, we'll be taking your questions live at the second part of the show. So thanks for joining us. We're going to let everybody jump on. I think we have our new timer system built in, so hopefully people are logging on right before the show starts. But we'll just chit chat first to get everybody, or give everybody a chance to log on. So we have been doing amazingly well lately, just so that everybody knows. Our success rates have been literally out of control. They are so good. So huge thanks to my team of amazing staff. We've added a new nurse, and she's incredible as well. So welcome, Kaja. We're really honored to have you join us, and really excited about everything that you bring with you and your skill set. So that's excellent as well. And everything is growing here at VRC, so we're excited about that. We're adding new people, and we're looking at doing some new addition to our size, and have to add about an additional 2,000 square feet because we've actually outgrown our space already, and we already had 8,000 square feet. So good things are on the horizon. We're very excited about everything that's happening. Thank you to all of you who have been watching and commenting. And thank you tremendously to everyone on YouTube who turned our COVID vaccine video viral. We now have 26,000 views as of today. And I think Tarek reported we had over 290,000 minutes of viewing last year. So that was kind of exciting to hear. We're really excited about that. And hopefully this year we'll do even better. So hopefully everybody's had a chance to jump on. Grab your tea, green tea only. Don't drink dark tea. And we're going to go through it. So there is a huge history to the endometrial receptivity array. And I want to kind of come clean about this because I was involved with it as well to some extent in the early stages. So in Chicago was the first time I heard about this at a conference, excuse me, called the Midwest Reproductive Symposium. And the Midwest Reproductive Symposium is a great little conference put together by several key players in the Chicago area, including Angie Beltzos, who's instrumental in putting that meeting together. So Angie, if you are watching at any point in time, thank you for everything you do. So at that conference, they brought some people from Spain, and they were from this original company called IVI, which is this huge juggernaut IVF corporation in Spain. And they had developed this test where they used this specific sort of metabolic and protein and hormone profiling of the endometrium to determine whether the lining of the uterus was what they called receptive or pre-receptive or post-receptive. And receptive meant that was the right time to put in the embryo. Pre-receptive meant you needed more exposure to progesterone. And post-receptive, which was extremely rare, by the way, meant you'd already had too much exposure to progesterone. So if you're receptive, you would transfer after 5 days of progesterone. If you were pre-receptive, you needed an extra day of progesterone. So the presentation was quite convincing. They talked about people who had failed. They ran this test on them. They went ahead and did the transfer, and they got pregnant. And then they also talked about women with really thin endometrium, and they ran this test on them, found out they were receptive, and they went ahead and did the test. So to me, this made a lot of sense. It sounded really great. Let's test the endometrium. No one's done this before. Let's see if it works. And I jumped into it. So we started doing it on our patients, and initially it kind of seemed like it was helping, but not always. So we thought, well, maybe it's fixing it in some cases, maybe it isn't in other cases. And over time, we started seeing some discrepancies, and we couldn't necessarily get everybody's window of implantation to be quite right, or when we would and we would transfer, it still wouldn't work, even when we had genetically normal embryos. So it wasn't making a ton of sense. So we kind of started drifting away from it after a while, and then I started realizing this really doesn't look like it's working. So I went into the actual studies, and the very first few studies that had come out on this actually showed no benefit. So as those of you who watch our show know, when we reviewed this about a month and a half, 2 months ago, we looked at the actual test trial that was run by iGenomics, the now parent company of the ERA test. And they ran an actual randomized controlled trial evaluating the utility of doing the endometrial receptivity, and their own trial showed no benefit to using the test. So despite this, I still see every day on social media or patients that are coming to us for a second opinion that they've been told that they need to do the endometrial receptivity array, and it's an expensive test. Our cost on doing the test was about $1,200, and we were charging $1,250 to do it. So we were charging $50 extra to run the test. It was about $750 for iGenomics, and our cost for doing ultrasounds and lab work and so on was several $100s. So altogether, it was quite a pricey test. So, we didn't want to do it if it wasn't making sense to do it. And so, I kind of shied away. And then that study came out and it said, this really doesn't work. So I said, okay, we're done now. Unless someone has a really thin lining that we cannot thicken. And I'm only looking to see if it's receptive, not for timing purposes, because I don't believe in their timing data at all. But I wanted to see if, it's actually useful just to determine, yes, we can do it, or no, we can't. So despite all of this information that we're sharing with you guys as well, people are still doing this test. So I thought, you know what, maybe we should dive deeper into this and see if there are specific subgroups that benefit or don't benefit. So I pulled up 5 different articles to share with you guys tonight, and I'm going to exclude one article that's very, very small. It had 20 patients, which did show a benefit. So disclaimer, there is one study out there that shows a benefit, but it's only done on about 20 patients, which is not really valid numbers for these kinds of comparisons and to make good decisions on. So the first study is called Routine Endometrial Receptivity Array in First Embryo Transfer Cycles Does Not Improve Live Birth Rate. So what's the first question? Well, the people from iGenomics claim that 17% of all patients have a displaced window of implantation, meaning you're going to be naturally pre-receptive or post-receptive during a hormonally stimulated cycle in preparation for an embryo transfer. So as a result, they said maybe it's better if we just screen everybody, because if roughly 1 in 6 are out of whack or out of kilter, then it's better to do it on everybody and you're getting 1 in 6 extra. So these guys actually studied this. And this is from the University of California, Wayne State School of Medicine, which is where I did my fertility fellowship, and the Reproductive Partners Medical Group in Redondo Beach. So some great people involved in all this, and they've all analyzed the data. So what did they do? They looked at 228 euploid frozen embryo transfers. So these are embryo transfers using genetically normal embryos. And they said 147 or 64.5% were ERA and personalized embryo, that's what the little P stands for, personalized embryo transfer cycles, and 81 or 35.5% were just standard cycles. So they gave them 5 days of progesterone and then they transferred it in. The rest of them they transferred in based on whatever the ERA test said. So it might have been 5 days, 6 days, 7 days, whatever was dictated by the testing. So what they concluded was the live birth rate did not differ between patients who underwent frozen embryo transfer with standard timing and patients who underwent endometrial receptivity array personalized embryo transfer, with 56.6% in the standard cycle getting pregnant and having a live birth versus 56.5%. So it is a 0.1% difference, and that 0.1 is actually in favor of not doing the test. So right from the get-go, if you apply this to just everybody and they have euploid embryos, it does not benefit you. And this is a live birth study, which again is the holy grail of all things fertility. Anytime you want to see the best outcome, you want to see what the live birth rates are. So in this study, and you can flip through it if you like, they did not show any benefit to doing the endometrial receptivity array. And if you go through clinical pregnancy rate, if you go through positive HCG, even if you go through miscarriage rate, they show absolutely no statistically significant difference between any of those outcomes. So number one, does it work if it's an unscreened population? It does not. So that element is useless. So that's one nail in the coffin from our little post in preparation for tonight's show. So the next study is called, does the endometrial receptivity array really provide personalized embryo transfers? So the question was, does it actually make a difference? Are you really getting a personalized transfer, and is it really making a difference for you? So this study looked at 503 patients. It does involve Bob Casper, who's a brilliant Canadian fertility specialist. He's invented half of the birth control pills are out there, and is really one of the forefathers of infertility. Extremely intelligent guy. So 503 patients in the control group compared to 41 patients who had the personalized embryo transfer with the endometrial receptivity array. So they looked at all the elements ahead of time to see if age, number of previous transfers, endometrial thickness, number of transferred embryos, and ongoing pregnancy rates were any different between the two groups. So these guys went through a little bit of additional trouble. They made sure that everything was perfect. The groups were lined up. They were lined up. So you got two equivalent groups. Different sizes, admittedly, but they're equivalent in terms of the percentages of all these different things. So what they looked at was, again, whether the patients had a difference or not. And they said that the women in the study group with pre or post-receptive endometrium on ERA testing, after getting the appropriate adjustment in timing for their frozen embryo transfer according to the ERA result, got a 33.3% pregnancy rate, which was 2% less than the 35.2% rate that the patients that did not get the endometrial receptivity array test got. So basically, and I won't go through all of the details of the study to bore you, you can see them up there on the screen. These patients had the exact same success, no statistically significant difference, no clinically significant difference, other than that it was actually a tiny bit lower when you use the ERA versus not using the ERA. So nail number 2. The third study is called Evaluation of the Endometrial Receptivity Array and the Preimplantation Genetic Test for Aneuploidy in Overcoming Recurrent Implantation Failure. So maybe there's hope for this test in the patients that have failed multiple times. What if you've had a bunch of embryo transfers? It didn't work. There's got to be something wrong. Let's figure out what that is. So people have thought maybe that's the endometrial receptivity array. So this is a huge study looking at 2,110 patients with moderate recurrent implantation failure. And they also had a significant number with severe, 488 patients with severe recurrent implantation failure. So moderate meant they had failed 3 previous embryo transfers, and severe meant they had failed 5 previous embryo transfers. So they went through these studies and they looked at the different groups, and they said that the PGTA analysis, meaning doing genetic testing to determine if your embryos are normal or not, is useful in reducing the recurrent implantation failure rates and increasing your success rates. But when they looked at the utility of doing the endometrial receptivity array, either on its own or in conjunction with the pre-implantation genetic testing, it showed no benefit. So I'll just share some numbers, and these aren't up on the screen, but I just want to go through them with you. So the standard, which was just garden variety, in the moderate group had a 35.9% ongoing pregnancy rate, and the severe had a 34% ongoing pregnancy rate. What does that mean? If you did nothing, you didn't get PGTA, you didn't get anything personalized, no ERA, no PGTA, you still had a 1/3 chance of getting pregnant. So reasonable. If you did the endometrial receptivity array, instead of 35.9, it was 36.25 in the moderate, and instead of 34 in the severe, it was 40% in the severe, but not statistically significantly different. If you did pre-implantation genetic testing, that gave you a 45.9% in the moderate and 36.1% in the severe, which they did say was statistically significant. And if you did PGT plus ERA, it actually brought down your chances. So you got 33.3% in the moderate, and you got 33.3% in the severe, compared to 45.9% for just doing the pre-implantation testing and 36%. So anywhere from a 3 to 12% decrease by adding in the results of the ERA. So again, when you have recurrent implantation failure, it doesn't help you. That is yet another nail in the coffin of the endometrial receptivity array. The next study was called The Role of the Endometrial Receptivity Array in Patients Who Have Failed Euploid Transfers. So what if you've just failed genetically tested embryos? And the question is, does it help in those instances when you've transferred these, but you failed the transfer of your genetically tested embryos? So you know they're euploid, you're putting them in, it's not working. So this was a smaller study. They looked at 88 patients who underwent the ERA testing, and they compared the outcomes. So this is from a wonderful group in New Zealand, and one of the guys involved is well known. So when they looked at this study, they said of the patients with at least one previously failed euploid frozen embryo transfer, 22.5% had a displaced window of implantation and qualified for this personal embryo transfer. So that's actually 1 in 4, 1 in 5 instead of just the 1 in 6. So they said that after the embryo transfer, they did find the rates were higher when you use the endometrial receptivity array. So this one's kind of an outlier. 73.7 versus 54.2 and 63.2 versus 41.7 for implantation and ongoing pregnancy. But there was no statistically significant difference. And this study isn't up on the screen for you guys, but I wanted to share this with you. It's saying the percentages are higher, but it wasn't statistically significant, which means even though you see higher numbers, it doesn't mean anything. They're not actually legitimately showing a difference. The final study is by a group from Spain, I believe, and it's what is the clinical impact of the endometrial receptivity array when, again, you've done genetic testing, and this time they even looked at egg donor cycles. So some people would say, well, it's not really harmful, I can afford it, let me make sure. Here's some interesting data for you. So there was no difference in implantation or pregnancy rate in the euploid, meaning genetically normal embryos, with the ERA versus the euploid non-ERA tested. The numbers, again, there's no statistically significant difference, but in this study, they actually favor not doing the ERA. So it was 58.3% for the ERA group and 70.6% for the standard group. But when they did this on the egg donors, it actually was statistically significant, and it's lower when you do the endometrial receptivity array. So it was 26.8% if you're tested with the ERA and 41.4% if you are not tested. That's implantation, and ongoing pregnancy was 34.4% when you have been tested with the ERA versus 65.2% when you have not been. So almost close to double the success rate if you don't use the ERA and you're using an egg donor. So for those of you who are using an egg donor, please do not do an endometrial receptivity array. It will actually decrease your chances, almost cutting them in half. And that was a highly statistically significant finding. So is there any utility to doing the endometrial receptivity array? I actually believe there is, and that one and only time is when you get a patient whose lining is so thin, nothing you do works, and you just want to see if they can be receptive or not. Because they will tell you that it is not receptive. Sometimes they can tell you pre, post receptive, and then sometimes they just say not receptive. So if you get a really thin endometrium where nothing you do works, it's probably usable there to tell that patient, listen, I'm not sure this will work at all in you. Forget the timing issue, we just can't get your endometrium ready. But for everybody else, PGT tested, non-PGT tested, recurrent implantation failure, first time, multiple previous untested failures, it does not work. And I can tell you from personal correspondence with the main guy at iGenomics that he once tried to tell me that it showed a benefit, quoting a study that actually showed no benefit. So I am 100% opposed to people doing this because it does not help and it doesn't make a difference. So don't bother wasting your time with the ERA test. I fell for it hook, line, and sinker. My apologies to those that did it with us earlier on. It made a lot of sense and we went for it, but as the new studies are showing more and more as time goes on, there is absolutely zero benefit to doing this test, so don't bother. So is it a fact or a fiction that the endometrial receptivity array can help you? It is a fiction. It does not help. Do not waste your money. And I'd actually discourage you from displacing your normal protocol using this because it can actually reduce your success rates if you do. So thanks so much for joining. Make sure you like, comment, and share on the website, and definitely subscribe to our YouTube channel where all of our videos are posted after the show. And if you have any questions or comments, we would love to hear them. Let us know what you think. If you did something that was different from what we see here, we'd love to hear about it and we want to know about that. So we're off to the remaining part of the show now. So if you guys have questions, I'm happy to answer as always. I will do my best. Fire away. And we got Tarek reading them out to us.
Okay. First question on Instagram. Let's start with Instagram today. They were abandoned last week.
You know, the apple tea is really good.
I told you.
This is Tetley apple cinnamon tea. It's delicious. So it's kind of like a tea cider. It's really awesome. And I don't get any promotional anything from Tetley, guys, in case you're wondering. Yeah.
If you had failed dual-stim cycle, is there anything that can be tweaked?
So a failed duo-stim cycle, if you failed both the first part and the second part, can't really be tweaked. I mean, it's probably the best of what's available right now for patients who have sort of poor embryo quality or lower numbers of egg yield. You could try a natural IVF cycle because there are patients that don't respond well to the medication. So that's a reasonable approach to things. And I'd encourage you to consider that option because we've had very good success rate with that. But within the duo-stim, there really isn't. Now, having said that, keep in mind that we just presented, was that 3 weeks ago? I'm going to be pointing up again. You got to be putting all these videos up there, man. So 3 weeks ago, yeah. So about 3 weeks ago, we had a video you guys can just look up on our YouTube channel where we actually talked about, you know, what happens if you've previously done poorly on an IVF cycle. And the response is only 11% of the time will you do poorly trying again. So there are things that can be adjusted and tweaked, but if you've done a duo-stim, you've really kind of done the best of the best. So you can certainly try again. You may do better the second time, and many people will, but there's not anything we're going to necessarily do different. We would actually probably do the same thing again and just hope you're getting a better result.
Should I take time off work following an FET, and what would you recommend eating warm food after?
Okay, so food-wise, the Mediterranean diet has been shown to increase your success rate. So the Mediterranean diet is composed of lots of fresh vegetables, fruit, fish, low in high carbs, very low in red meats. So that's kind of a reasonable dietary approach for you. You don't want a lot of sugar, you don't want a lot of cholesterol, avoid caffeine as much as possible. In terms of avoiding work, that actually has been studied and no one knows for sure. There are a few studies that actually support the idea that you should go back to work right after your frozen embryo transfer or fresh embryo transfer. But in my opinion, you should really do whatever stresses you the least. I think that it's the stress that plays the role. So some people are better at work because their mind is off of the embryo transfer and they're just distracted and they can go about their business, and that's going to have a better outcome because they're not sitting there on Google wondering, oh, was that twinge, you know, some kind of problem? Am I going to fail? Oh my God, it didn't work. Whereas other people go to work and they're cringing because they're at work and they have to deal with things that are problematic or difficult, or colleagues that are problematic and difficult. So if you are in either of those two categories, choose whichever thing is going to calm you the most and do that. So if you're calmer at home, stay at home, but stay off of Google. For the love of God, do not go on Google. And if you are calmer at work, go to work. Yeah. That's a good question.
Do you do the IVF transfer yourself? I developed cysts prior to my FET that eventually went down in size. Will this compromise my success rate?
I do all my own frozen embryo transfers. We are growing very rapidly, but I don't think I'll ever give that up because I'm very specific about how I do them. And we talked about it on our last show, but we kind of mastered how to do transvaginal ultrasound guided embryo transfers. So for our patients where they really have a difficult time or it's not working, that's what we do. Or we have difficulty seeing their uterus because it's retroverted, retroflexed, we do transvaginal ultrasound guided transfers. Very, very few people know how to do that, and you've got to do it very, very well to make it work right. So I do all my own for sure. As far as cysts are concerned, cysts usually go away. So birth control pill, for those of you that are comfortable with that, for a month or two, usually will take care of it. You can get drained, and we do that right here in the OR. Just like an IVF egg retrieval, we just drain the cyst, and sometimes that does it. And other times you actually need to have additional therapies. So there can be surgery involved as well. So wait and see is usually the first approach, and then if it's not going away within a couple of months, we usually dive into one of the other approaches. Probably start with just drainage and then move on to an actual embryo transfer after surgery if we had to.
Just wondering if you can tell me how much does IVF cost with no benefit plan?
So we start at 6,000 Canadian. It goes up to as high as 22,000 if you want a live birth guarantee. The most common package is 9,995, and that's for all of our patients who are kind of garden variety, just doing the normal IVF protocol. That includes everything but the medications, and it doesn't include genetic testing. So if you're having genetic testing, it's extra for pre-implantation genetic testing, especially if you need monogenic disease or disorders testing. That's an additional expense. But most of the clients are paying $99.95. That includes absolutely everything, including your first year of freezing. And they get a full IVF cycle out of that. You just pay for your medications. Thankfully, in our area, most of our patients have coverage. If you don't have coverage, it very much depends on how strong your ovaries are. If they're really strong, then you're looking at around maybe $3,000 to $4,000. If they're not so strong, it can be anywhere from about $4,000 to $6,000. Sometimes more, sometimes less, depends on your ovaries and how robust they are.
Hello, Dr. Victory. Is it possible to get an LH surge but not ovulate due to immature egg?
Possible, yes. So in a circumstance where your estrogen level is very high and you are producing a significant amount of estrogen, your brain will actually think that you are surging or supposed to surge because it thinks that you've got one really big egg there. And if that happens, then what ends up happening for you is that you actually will send an LH surge out, but your follicles will not be mature enough. So if that happens, it's typically because we've given you shots, but didn't give you an agonist or antagonist to block the release of the eggs until they were mature. That's pretty uncommon, but it can happen. Yeah. Good question. I was
Dr. Victory,
challenge me.
Just wondering, the effects of hypothyroidism with TTC. My thyroid have been stable for 2 years now, so just wondering if it would still have an effect on fertility.
So you want your TSH less than 2.5, and you want to minimize any antibodies that you have. There are many studies that show that your thyroid can have an impact on your fertility, both in terms of conceiving and staying pregnant. So if your thyroid is not functioning properly, it is very important that you get it to function properly. So get your TSH checked, get your free T4 checked, and then check your antibodies. So that's thyroid peroxidase and antithyroglobulin antibodies. Make sure that those are low or negligible, ideally. And if they're not, then you sometimes have to either increase your TSH administration or start your TSH administration so that you are driving down your levels, and that way you are actually getting an improved outcome.
What can be done naturally to help with late ovulation and short luteal phase?
Naturally, see Jennifer Strong, our naturopathic doctor. So actually that's where I turn to supplements, and I turn to helping patients by using some of our associated agencies. So we'll use traditional Chinese medicine, we'll use naturopathy. I haven't really met a homeopath yet that wants to work with us, but if there's one out there, we're happy to talk to you. Bottom line is you really need to explore those options. So if you have, for example, PCO, and that's what's making you ovulate late, inositol, NAC, coenzyme Q10, the omega-3 fatty acids, these have all been shown to be of benefit, and they're in our previous video where we reviewed natural therapies that work for PCOS. So those are really reasonable things to try naturally that can help you. Weight loss, exercise, these can help as well, dietary changes. Acupuncture can probably do some wonders as well. So there are some things you can do that don't involve meds or hormones. They can just be vitamins and supplements and so on, and natural approaches, like I said, healthy diet, lots of exercise, weight loss. But shy of those kinds of things, from a medical standpoint, there actually isn't a lot we can do for you that alters it.
I got two inositol questions that are two different questions.
Okay, fire away, yeah.
So first inositol question, is inositol beneficial if you don't have PCOS? And the second one, is inositol safe to take while breastfeeding?
Inositol is definitely safe to take while breastfeeding, so that's not an issue. It's safe all the time. And is it beneficial when you don't have PCOS? Probably. It does have anti-inflammatory properties. So we need more studies on that, but it likely is beneficial because anything that is antioxidative, anti-inflammatory is beneficial usually for fertility. So I'm going to give that a qualified yes, but it's a qualified yes. So it certainly has no harms that we're aware of, and it's likely going to be beneficial.
Hi, Dr. V. For a FET, would you transfer a day 6 euploid embryo or a day 5 or a day 6? I've seen a few studies indicating day 5 is better, but my office does day 6 for a day 6 embryo. I only have one. Thanks.
Okay, so I think you're asking us if you had a day 5 embryo, would I transfer day 5 or day 6? And if I had a day 6 embryo, would I transfer day 5 or day 6? So we reviewed that on a previous Fact or Fiction, and that Fact or Fiction showed that it's actually got loads of views too. I think we have about 8,000 or 9,000 views on that video. So I think it says day 6 or 7 because you're actually talking about 5 full days versus 6 full days of progesterone exposure, which is transferring on the morning of day 6 or the morning of day 7. So in that video, we explained that if you have a day 6 embryo, like they froze your blast on day 6, it's likely beneficial to transfer after 6 days of progesterone because it actually decreases the miscarriage rate. But if it's a day 5 embryo, it makes no difference if you transfer on day 5 or day 6. So we have loads of patients whose lining is not ready by day 5, like after 5 days of progesterone exposure because it hasn't compressed yet. So we wait the extra day, and this is another reason why the endometrial receptivity array is useless. And then we transfer them the following day, and they're all getting pregnant. So I don't think that it matters if it's a day 5 embryo, but if it's a day 6 embryo, probably aim for 6 days of proj. Great question, and check out the video we have on it.
If 7 eggs were retrieved, 5 were fertilized, but then none grew to day 5, what would you suspect could be the issue?
So it could be the sperm or the egg. You'd have to sit down with your lab director, have them look at the quality of the sperm, have them look at the quality of the egg, and they'll be able to figure it out. Usually early on like that, it's often going to be the sperm because it's the sperm that actually has the mechanism in it for division of the cells in an embryo. So very commonly that's what's going on. But it's a case-by-case basis, and they really have to decide that. And embryologists don't necessarily agree. So I once asked an embryologist that exact question when at their center they had a bad outcome. And then I asked my embryologist to review that same case, and she said the exact opposite of what the other embryologist said. So, it's hard to know for sure, but my suspicion would be bad egg quality or bad sperm quality, most likely a sperm quality issue. Most likely.
My husband's sperm counts are 1.5 million. Do we have a chance to get pregnant naturally?
Do you have a chance? Of course. How high is that chance? It's probably substantially less than 1% per month. So I'm sorry, my heart goes out to you. It's a very, very low chance when your sperm count is that low. If it's 1.5 million, just the raw count, keep in mind that there are going to be losses in terms of the number that are moving, the number that are alive, the number that are normal, and how fast they're moving, and so on. So you're really probably ending up with only a few 100,000 at the end. Maybe even less than that. That will be very, very difficult to succeed. Sorry, that's a situation where that would be considered severe male factors. So we're certainly willing to try IUI, but even with IUI, you're going to get less than a 5% success rate. And with IVF, you'd have a very good success rate as long as they know how to pick the right sperm. And that needs ICSI for that kind of case.
Hi. You answered one of my questions last time. I did a receptive test.
Receptiva. Yeah.
Receptiva DX.
Yeah. Yeah.
Okay, test. And someone else. And it came back positive for endometriosis.
Right.
The doctor said 2 months of Lupron.
Right.
Should I be adding or doing anything different? I failed multiple donor egg transfer.
Okay, so first of all, if you failed multiple donor egg transfers, I'd actually recommend you get surgery to see if you have endo, because if you do have endo, you need that dealt with. Number two, I would do an immune workup. I would get the lining of your uterus checked from Fertility to see if you have any infections in there, and make sure it's okay. I think I remember this question. I had the same answer last time. Having said all of that, Receptiva is actually not useful for detecting endometriosis. There is only one way to detect endometriosis, and it's surgical. So if they're going to treat you as though you have endo, the appropriate protocol is a low hormone-based diet. So eat everything natural, organic, stay away from anything with hormones in it. Number two, you want to do Lupron and Letrozole for 3 months. And this is with all due respect to all of the patients out there who are suffering from the effects of Lupron. There are a lot of patients out there, and we're going to explore this with them. I'm trying to put together a conference for the Lupron victims. So we still use it because I haven't seen raw data yet that's supporting, side effects from the Lupron that are permanent, but there are a lot of women out there claiming it does have side effects. So with that caveat in mind, you can use Lupron for 3 months with Letrozole, and I would strongly recommend you take the supplements that we recommend, which is also in our Factor Fiction video on natural supplements for endometriosis. So those include NAC, you can use inositol, NAC is N-acetylcysteine, by the way, and curcumin or turmeric. All of which have shown that there are benefits in patients with endo. So try those, they can be beneficial, help suppress the inflammation. I'd also recommend that you try a protocol that uses minimal hormonal therapy as natural as possible to minimize the chances that the endo is messing things up.
Hi, Dr. Victory. What is your view on those progesterone proof tests to confirm ovulation for natural conception?
Not sure what you mean by progesterone proof, but you can just come and get your blood tested, and that's fine. If you have an LH surge, most of the time you're going to ovulate. Again, the only time you wouldn't is if you had immature follicles. So if there's like a urinary progesterone test, if that's what you're referring to, that would be fine.
What is the protocol for people who are doing IVF with high AMH and follicle count to get the most eggs but avoid OHSS?
That's actually pretty easy. All you need to do is use a GnRH agonist trigger like Lupron, but it's not the long-term kind. It's a small dose all at once, which doesn't have side effects. And then there was one study that showed that because those patients need to go on to do frozen embryo transfers, a very small amount of HCG is beneficial. Some people argue that you will still get hyperstimulation with that. We really haven't seen it. So we use Lupron with 1500 of HCG with outstanding results, and we get very, very low rates of hyperstim.
Hi, please, what's the minimum sperm count to do IUI?
Well, there is no minimum sperm count to do IUI. The question is, how successful are you going to be? So we have a fact or fiction on that from several months ago, which showed that 14 million was the main factor that predicted your success rate with IUI. And that 14 million is total motile count, which is the number of milliliters of sperm times the concentration of the sperm, which is number of million per milliliter, times the number that are moving. So there are other factors that go into it. How fast are they moving? How many are normal or abnormal, and so on. And then DNA fragmentation. So it's becoming more complex than just saying what's the minimal number. But if you're under 14 million, your chances are less than 5%. So that's what you need to know, because that's really important. If you're over 14 million, your chances are reasonable. And again, reasonable is anywhere from about 10 on the low end to about 25, maximum 30 on the high end for doing an IUI. So if you're in that 1.5 million range, you're struggling. It's going to be very, very difficult. That really does need IVF most of the time. You're certainly welcome to try IUI. And especially if you're somewhere relatively inexpensive like us, we don't charge a lot. It's $350 Canadian for an IUI, or $450 if you're using the Zymo device that screens out the abnormal or high sperm DNA fragmentation sperm. So for $350, $450, it's totally worth it. But if you're spending thousands doing it, it's not worth it. Don't do that.
Do the stats on fresh versus frozen transfer success specify if it's male or female infertility? Considering fresh with our next cycle, MFI only low count. I am 30, healthy, and no known concerns.
So again, we have some great videos on that, and one of them has, I think, 16,000 views now. So you can find it quite quickly because it's up at the top of the YouTube heap. On our website, on our YouTube channel. So the reality with that is that on balance, for the majority of patients, if you're producing a high number of eggs, not embryos, a high number of eggs, your estrogen level is going to be really high. If your estrogen level is going to be really high, then you're going to benefit from doing a frozen embryo transfer. It won't work when you do a fresh embryo transfer. On the flip side, and this actually has been supported by data, if you're 43 and you're only producing 1 egg or 2 eggs, and you're not going to do genetic testing, which you probably should do, but in the event that you're not going to do the genetic testing, you should actually be getting a fresh embryo transfer because the success rates are higher that way for that specific group. So high number of eggs, young patient, really healthy, everything's good, do a frozen embryo transfer. But if you're a low egg producer, low estrogen levels, you're older, you should probably be doing a fresh embryo transfer.
Do you believe in less stimulation IVF for people with lower AMH?
Yeah, so I've looked at this and I was going to present this. We probably should one of these shows. Maybe next week or the week after we'll do this. So, mini IVF has not actually shown a significant benefit. There are some studies that say it's better, and then there are many studies that say it is not better. And there are many, many studies that show that the more eggs that you have, the better your outcome is. So, it's kind of hard to justify mini IVF. Having said that, for us, what I now do for our patients that have lower AMH is I either go straight to natural cycle IVF, which I love. It's low stress, it's low cost, there's minimal shots, you don't have to spend a fortune. The patients do great, and the embryos are beautiful embryos. They always get really pretty embryos from those cycles. So we do a lot of natural cycle IVF, and if you're not satisfied with just the one egg you're going to get from natural cycle, then we do the duostim, and duostim has been quite good for us. We see good results. Granted, I severely discount the second cycle to make it feasible for patients to do it twice in a row. And because we try to be really nice to patients, we frequently let them in on the duostim even if they didn't plan for it from the start. So if they're doing 2 back-to-back cycles, we'll drop the price almost 35%. It's actually 37%. To help facilitate that for them. But, it's up to you. I mean, if that's something you want to try, we can try it. So low AMH, the duostim has shown promise. There's lots of data now supporting that it's beneficial. Natural cycle IVF, in my opinion, seems to be beneficial. The mini IVF, not really a big believer in that. I don't think it works that well.
It has taken me 3 egg retrievals to get 2 PGT-S normal embryos, getting ready for transfer, and was considering ERA. But this was very informative. Do you recommend any other tests prior to the first FET?
It depends on the cause of your infertility, right? So that's a tough question to answer. If you have endometriosis, surgery or treatment are all very reasonable. If you've had previous infections, chlamydia, gonorrhea, look at that fertility testing. If you have an overactive immune system or autoimmune diseases, consider immune testing to make sure everything is optimized before you go into it. So it's kind of hard to just kind of blanket statement, hey, you should do this, that, or the other thing. Everything in fertility should be custom tailored to you. We always use the expression that we're not baking cookies here. This can't be cookie cutter medicine. So making babies is complicated, it's sophisticated, and you need to get individualized care. If they're just tossing you into the IVF grinder and treating you like everybody else, you're not going to get a good result. So I definitely recommend some testing where it's indicated. If you only have 2 genetically normal embryos after 3 IVF cycles. So first of all, you have an 84.5% chance, I think, or 84.1% chance of success. So that's wonderful. Congratulations. And that's for live birth. And number 2, you need to be really cautious. So yeah, I would recommend going through your history, sitting down with your fertility specialist, make sure they're spending the time with you to go line by line through every single thing that pertains specifically to your case and find an approach that is tailored to you. It should not be, well, this is just what we do. That's the wrong answer. I need to know what they're going to do for you. And that's the way we do it.
What is the ideal progesterone level after ovulation during the TWW to support a pregnancy?
That does not exist. So that's a great question, and I applaud you for asking it, but there is no ideal level because in a natural cycle, we don't know what level is necessary. You can get women with low progesterone that get pregnant and stay pregnant, and some with high progesterone that don't. So in a natural cycle, we don't know. Now, do we support our patients with progesterone when they're doing fertility therapy? We do, because we think it's beneficial, but even that is equivocal in the data, and many people say it actually doesn't help. So IVF, we know for sure it helps, but that's a whole kind of approach to things because those patients are not producing their own progesterone necessarily, especially when we're using suppressive medications.
What do you recommend for DOM? And do you recommend for someone with a triple threat fibroid low egg count, and closed tubes?
I don't know what you mean by DOM. I think you mean diminished ovarian reserve, so hopefully you meant DOR. I'm not familiar with the term DOM. So if you are asking about DOR, DOR is the same thing as low AMH. So natural cycle IVF is reasonable. Doing the duo stim is reasonable. If you believe in mini IVF, you could try mini IVF. There are different protocols people use. Some people use letrozole. Some people use testosterone priming. We use the microdose flare with testosterone priming. There are ways to try and get you to make more eggs. So any of those is considered reasonable. What would I do if you had fibroids, diminished ovarian reserve, and what was the other part?
Triple threat, fibroids, low egg count, and closed tubes.
So your tubes, you have to make sure that they're not filled with fluid. If they are, they need to be removed. Fibroid, if it's large, like bigger than 4 centimeters, or it's pushing into the cavity of the uterus, it should definitely be removed. Diminished ovarian reserve, as I mentioned, there's different protocols. So surgery may be in order for you, and that's something that's really important and critical for you to consider.
Hi, Dr. Richard.
Hello.
Any truth to prednisone IVF protocol causing low birth weight?
No. Prednisone during pregnancy will cause low birth weight. So if you continue on it for a long time, it can, but not early on when they're doing it, usually with an IVF cycle.
Does letrozole have any effect on producing more follicles and or quality of follicles?
No effect on quality that I've ever read about. More, yes. So letrozole will sometimes make you make more than one egg. It's not quite as strong as other agents like Clomid or certainly the shots, but there are women that have multiple follicles that develop on letrozole.
Hi, Dr. Victory. Can you take inositol and metformin?
Yep, we do it all the time. So I have a triple approach to PCOS. So we have letrozole and metformin, which I call the medical approach. We have inositol, NAC, and coenzyme Q10, which I call the natural approach. And then we get all of our patients who are in the heavier PCOS category to do exercise and eat 6 meals a day with 1,500 calories max. So breakfast, snack, lunch, snack, dinner, snack. And you have to keep it under 1,500 calories with hardcore exercise. Walking is not exercise, guys, so don't use that as an excuse. We're talking T25, P90X3, 25, 30 minutes of like, oh my God, I'm gonna die kind of exercise. Yep.
Can AMH level of 4.34 ng over ml and irregular cycles be PCOS symptoms?
Sure, yeah, it can. I mean, PCOS requires other symptomatology, irregular cycles, acne, hair growth, weight gain, hair loss from your scalp, oily skin, central adiposity, these sorts of things. So it's not just about levels. In fact, many places don't use those as criteria. There's a study coming out, which has not yet been published, that says that your neck circumference is actually a reasonable measure of PCOS. So I haven't read the full study yet, but it looked interesting when I caught the abstract the other day. So yeah, I mean, there are different measures, but the bottom line is that if you have a high AMH like that, and that would be high, and your periods are irregular, it's certainly possible.
Is there any study to show low ferritin or iron stores impact fertility?
Yep.
And if so, does this affect quality?
I don't know about quality, but there was a study published, 6 months ago or so, that showed that ferritin does impact it. So we actually test our patients for ferritin levels and put the patients with low ferritin on iron.
Can high prolactin levels affect IVF? We have MFI, our RE determined my PRL level 3, BW29, 122, and 43 UG over L.
Okay, let me look at that one because that one was way up.
Prescription.
29, 122, and 43 microgram, but is not concerned. Other hormones are okay. Should it be fixed before IVF? Yeah. Okay, so hyperprolactinemia should be fixed before your IVF. It will impact your egg production. It'll impact your implantation. I have a phenomenal story to share about a couple that had gone to another center and were not happy about the care that they received there. So through some medical friends, and they may be watching the show right now, so no names will be used, they reached out to me and we've had several conversations. And after doing some investigations, I found out that the very lovely young lady had hyperlactin. So I said, listen, we got to treat this first, and then we can deal with all the other stuff and start getting you ready for another IVF cycle, which she was interested in doing. They as a couple were interested in doing. So we treated it, and she got pregnant just recently and showed up with a positive pregnancy test without doing anything. I didn't even need to do the IVF yet, which for me is a huge win, because unlike a lot of places, if I can get you pregnant naturally without having to do IVF on you, I consider that the best outcome possible. So you do need to get it treated. Hyperprolactinemia is for sure an obstacle to getting pregnant, even when you're doing IVF.
I have persistent fluid in my uterus cavity. No.
Ugh. Isthmusal?
Yeah, and no hydros.
Salpinx.
Yeah. My doctor wants to try Orilissa. What are your thoughts?
So if you have persistent fluid in your uterus, first of all, you probably do have an isthmusal, because that's by far the most common cause, or there is fluid in your tubes, which would be the second most common cause. If it's neither of those, then you must have something going on in the uterus, like infection, so I'd check for that. And if there's still no infection in there, it is very, very difficult to get rid of the fluid. I can't see how Orilissa would help. I mean, it'll shut down your endometrial production for a while, so I've never read about doing that, but that's not probably going to do anything, especially if the source is infectious or inflammatory, because as soon as you go off the Orilissa, it's all going to come right back again. So I would screen for infection. I would get rescreened for an isthmusal. If you've had a C-section previously, and now you've got fluid in your uterus, and I'd be super interested to have you share, who is that? IVF fighters or fighter?
Plural.
IVF fighters. So if you have had a C-section before, I guarantee you've got an isthmusal, even if they didn't see it. You need someone who knows where to put the balloon, which has to be in your cervix in order to see it, because otherwise, frequently the balloon will go from the catheter, will go into the isthmusal, and you actually are obstructing the isthmusal and can't see it on the ultrasound. So you need a saline infusion sonohystogram with a sagittal view, and you need to have the catheter in the cervix when they do the flush to be able to see if there's an isthmusal there. So check that before you do anything else.
That's a good one.
That was a good one.
Can one multivitamin be used by both man and woman and get fertility benefits? I found a brand that says works for both.
Sure. I mean, they're mostly the same vitamins, so there's no reason why you can't do that.
Will this be uploaded to YouTube? I missed some.
All of our videos are always uploaded to our YouTube channel. So www.youtube.com/drvictory for Dr. Victory. Make sure you like, comment, and subscribe, and share. We want this to grow huge. So our COVID vaccine video has gone viral. We have several videos in the works when Tarek and I actually have time, maybe this weekend. So we're going to do one on sex during fertility and what helps liven up your sex life. We're going to do one on marijuana and the effects of marijuana, and we're going to do an update on the COVID vaccine. So yeah, all of our videos are on our YouTube channel.
For my recent IUI, I had 24-hour trigger versus 36-hour for my two previous IUIs. What is the reason for different timing?
There is no difference, and frequently the girls will do it based on how close your eggs are to the right size, so they kind of feel like maybe we should move it up a bit if the eggs are more mature, or if they think maybe you naturally surged a little bit earlier. So they will make those decisions, or I will make those decisions once I've looked at your case. So it has been studied. There's no difference between 24 and 36-hour IUI, so you could do either one. It could just be convenience. It has absolutely no difference in outcome. We're done.
Well, you're not done the questions.
Oh.
But I'm just giving you the heads up.
Oh, it's 9.
That's the 9 o'clock heads
5
up.
more minutes?
Whatever you need, boss.
All right, let's give it 5 more minutes, guys. We'll answer a couple. Are there still tons of questions?
You don't run out.
All right, 5 more minutes.
Okay. Would you recommend TESE or micro TESA for high DNA frag, 48%, or would IMSI suffice?
So IMSI, which we just reviewed 2 weeks ago, doesn't help. So don't bother with IMSI. I wouldn't recommend either of those for DNA fragmentation because it won't help you. So there's a very good study which shows that if you just do an ejaculate sample, wait 3 hours and do a second ejaculate sample, the second sample has markedly reduced DNA fragmentation. And the device from Zymo also will reduce it by 90%. Those other techniques are useless, so don't spend a ton of money, or for God's sakes, don't subject your partner to having his testicle filleted open to do something that won't help. Tarek just passed out for those of you that missed it. He didn't like the testicle fillet thing. So yeah.
All right. Does letrozole can have the effect of unknown cell in a long run? My PAP result abnormal for the first time after multiple letrozole doses.
No, has nothing to do with letrozole whatsoever. Pap smear abnormalities are 100% caused by transmission of a virus called human papillomavirus. And so that's the only thing that causes abnormal pap smears. Nothing else. Has nothing to do with any medication.
Hi, doctor. I have low AMH at 0.16, age 37, and factor V?
Factor V Leiden.
Factor V Leiden.
Uh-huh.
This is my third IUI, and doc wants to use tamoxifen instead of letrozole and won't use estrogen to help thicken the lining. Any thoughts on this drug?
If you're factor V Leiden, you should be on heparin and probably aspirin, and then go ahead and use estrogen. It's not going to do anything to you as long as you're on heparin. So I don't know why your doctor is doing that. You'd be perfectly fine to use it. You could even use shots or estrogen for thickening the lining or whatever you need. So that won't make a difference. Tamoxifen for fertility is a very, very rarely used. It does have a blood clot risk, though, that is actually much higher than anything else, including Clomid. So I would not recommend using tamoxifen, especially if you're factor V Leiden positive. I'm not sure your doctor has thought of that yet from what you're saying to me. So talk to them about it, but I don't use tamoxifen. It tends to cause endometrial effects that aren't great. They're probably using it because it might thicken your lining. It's very pro-estrogenic in your uterus, but tamoxifen can also cause blood clots. So like DVT, PE blood clots, which are dangerous, and you're at a much higher risk when you're factor V Leiden. So you need to be anticoagulated and then do whatever you want.
Do you recommend biopsies to rule out endometriosis between retrieval and FET in patients with a history of this?
Okay, biopsies from the uterus don't show you endometriosis. They'll show you endometritis. Is that what it says? Or?
Endometritis.
Oh,
sorry.
No problem. So yeah, if you've had a history of recurrent failures, we recommend it for sure.
What is the effect of increasing the dosage of letrozole from 2.5 milligrams to 5 milligrams or higher?
You know, we actually just go right to the 5 milligram dose. I don't bother with the 2.5. It's stronger, and most patients will ovulate on it, and it's pretty rare that I need to go above 5. So we just use the 5 milligram dose.
I had a blood clot after my myomectomy. Will that affect my implantation after a transfer?
Okay, so if you mean you had a deep venous thrombosis, a DVT, or a PE after a myomectomy, the big question is, did you have it because you had surgery, which is common, or did you have it because you were predisposed from a thrombophilia, a condition which predisposes you to blood clots, and then you had surgery, which makes it worse, and you're lying down flat for hours, and your blood's not circulating as much, and you're dry, and so on, so you're increased risk of clotting. So if it's just that it was post-surgical, I wouldn't worry about it. But if it was because you have a thrombophilia, which you should be tested for, then you need to be anticoagulated before you do your embryo transfer, because it does make a difference. There's lots of anticoagulation
Yeah.
questions. Yeah.
We are thinking of freezing my husband's sperm for future IVF due to low testosterone and possible TRT. Does each IVF cycle require a separate sperm sample, or is one sufficient for 2 IVF cycles?
That's a fantastic question. And the answer to that is if your husband's testosterone level is low, he does not necessarily need testosterone replacement therapy, which is TRT. So you can take Clomid for men, which will naturally improve your sperm count and increase your testosterone. You can do HCG shots, which will do the same thing. And you can also do FSH, although that's kind of hardcore. So there are natural ways to do it. Diet, exercise will help quite a bit. Making sure there's weight loss if he's heavier, that helps tremendously. Eliminate alcohol, that's a huge thing. Eliminate smoking, that's also huge as well. So there are lots of things you can do naturally without needing to get too involved with hormone therapy necessarily. Although obviously the Clomid and the HCG and so on are not that natural. In terms of how many you would need, it actually depends on how good the sperm sample is. So if he has very good sperm, one ejaculate can be split into a sufficient number of vials to power several IVF cycles. If he has weak, you may need several samples just to do one. So it depends on what his sperm quality is like. I can't answer that without knowing the numbers. And actually, I'd leave that decision up to my lab director and embryologists. They are the ones that decide that.
Great final question.
Great final question. All right.
If it's the final, that's up to you. But I think it's good.
We need a drum roll. Brrr. You got to put that into the...
I'm going to load that up. Final question gets a drum roll. New
All
rule. What is mini IVF, natural cycle IVF, dual stem compared to regular IVF? And what do you suggest with good AMH? And am I in my 40s? Thanks, much appreciated.
Okay, so I'm going to start with natural cycle IVF. Natural cycle IVF is where we take advantage of the fact that your body is going to produce one egg. You can either use no meds, dangerous because frequently the egg will release on its own, or use a minimum amount of meds just towards the end when the egg's like sort of 12, 13 millimeters. You help that egg grow without letting it release. You trigger the release of the egg, you go do your IVF, you retrieve the one egg, you turn it into an embryo, you can grow it, biopsy it, freeze it, transfer it, whatever you want. You have all the options. So that's natural cycle IVF. Mini IVF is where you keep the dose of gonadotropins at 150 international units total or less. So usually 75 or 150, and you're really aiming to get about 2 or 3 eggs. So it's a normal IVF cycle with a very low dose of medication. You don't go over 150. Standard IVF is standard IVF. Measure everything, check the patient out, and then go ahead and give them whatever medication protocol you're going to with a reasonable dose to try and get as many eggs as possible without necessarily overdoing it. And duostim is when you have a back-to-back IVF cycle with a 5-day interval between. So you go from your normal follicular phase stim, so you have your period, you come in on day 2 or day 3, they start you on your shots. You get to the part where your egg is mature, most of the time 8 to 11 days of shots, you trigger the release of the eggs, 36 hours later you do your egg retrieval. You do your egg retrieval, you wait 5 days, you restart the shots, you watch how the eggs are growing because there's a second wave of eggs that probably started growing during the last egg retrieval cycle. And then you go back and you get those other eggs. So we're huge fans of doing duostim because it works really well and the data supports it. And again, we're doing it for an insanely low cost for our patients to help them out. So my business manager keeps yelling at me, telling me we're losing money, but I'm happy to help people. If I don't have to, lose the business, I'm okay with it. So we're good to help patients out and make that work. So for you, if you are healthy, you're 40, and you're capable of making a lot of eggs because your AMH is quote unquote good, and I don't know what that means, but if your AMH is good, then you should have a standard IVF cycle, because at 40, if you watch our embryo math video, which is not a fact or fiction, but we just put up on the YouTube site, and is a great video that actually walks through what your actual chances are for your success with IVF. Then you will see on that video that it has about a 70%, 72% rate of aneuploidy, meaning your embryos will be genetically abnormal at 40. And so if that's the case, you need several embryos just to get one normal one. And with that in mind, the more eggs you make, the better the chances that you will find a couple that are normal. So you want a standard IVF cycle to try and make as many eggs as you possibly can. DuoStim will help you make even more, but it's designed for women with low egg yield. It's not designed for women that can produce tons and tons of eggs. So if you did that, you'll give them really bad hyperstimulation, and that's not a good idea. So don't use it if you're a high egg producer. You're better off doing one IVF cycle, making some embryos, freezing them, waiting for the biopsies to get enough, and then doing another IVF cycle again if you need more embryos. Are we signing off? That was a good question.
I thought you'd like that.
I think that was a good question. Okay, guys, so lots of love to all of you. I'm going to go home because I was up all night delivering babies as usual. And that was a great show. Thank you for joining us. Make sure you watch the embryo math video on YouTube. Make sure you watch the COVID video on YouTube. Like, comment, subscribe, and hit that subscribe button. It's important for you to follow us. We want to make sure we get you the latest and greatest of information all the time. Have a great night. Stay safe. Wear your masks. Good luck in your journeys, guys. Take care.